Well, hello. I want to welcome everyone to today's webinar on program evaluation for promising home visiting approaches. My name is Nancy Margie, and I work in the Office of Planning, Research, and Evaluation, or OPRE, of the Administration for Children and Families. Today's webinar is one in a series of webinars prepared by the, let me get to my slides, by the DOVE team. DOVE stands for Design Options for Maternal, Infant, and Early Childhood Home Visiting Evaluation. It is a contract that was set up by ACF and HRSA and is working with us to support the federal maternal, infant, and early childhood home visiting program. Specifically, the DOVE project is developing design options for a federal evaluation of evidence-based home visiting programs. It's also providing evaluation-related technical assistance for promising approaches, such as this webinar, and also TA for grantees' continuous quality improvement, or CQI, management information systems, MIS, and on benchmarks. And the team involves James Bell Associates, MDRC, the Cincinnati Children's Hospital Medical Center, and Every Child Succeeds, as well as a host of academic consultants. And for today, I am delighted to introduce our speakers. First, we have Charles Nicolopoulos, who is the Senior Fellow at MDRC and an expert on statistical methods for estimating the effects of social policies. He is currently the co-principal investigator of the Design Options for Home Visiting Evaluation Project, and he is also leading evaluations of coordinated care programs for aged, blind, and disabled Medicaid recipients in Colorado and New York. And he's leading the impact evaluation of Supporting Healthy Marriage Project and the Working Towards Wellness Telephonic Care Management Program for depressed Medicaid recipients in Rhode Island. He has numerous publications on the effects of social policies and on methods for evaluating those policies. In addition, we have Chris Blodgett, who is a faculty member in the Washington State University Department of Human Development and a licensed clinical psychologist. Dr. Blodgett has been the principal investigator for more than 36 federal, state, and national foundation grants addressing high-risk children and families. His current work in home visiting includes conducting an ACF-funded randomized controlled group trial of enhancements to the Nurse-Family Partnership Program, and he has responsibility for the evaluation of a state-funded expansion of home visiting services in Washington State. And I am now going to turn it over to Chuck to start our program. But before I do that, just in case anyone needs them, slides for this webinar are available on the MDRC DOVE project page website when you want to download and print them. And with that, I turn it over to Chuck.
Okay, great. Thanks, Nancy. So let me start just by briefly going over what the goals of today's session are going to be, and then we'll launch into some of the details. First, I'm just going to briefly summarize the requirements for evaluations of promising approaches. This will come really pretty much straight from the supplemental information request that you all have probably seen. I know there was a phone call earlier in the week that went over these requirements as well, so this will be kind of a brief review of that, or for those who couldn't join the phone call, a little bit of an introduction to that. Then we'll turn to discussing whether a state should actually conduct an effectiveness study of promising home visiting approaches, or instead just do a process study to study the implementation of those programs. After that, we'll turn to a brief summary of some different evaluation designs and what the implications might be for the decisions that you make about doing an effectiveness study. After that, I'll turn it over to Chris, who's going to provide a brief overview of developing an evaluation plan, and then talk a little bit about guidelines for participatory and empowerment research practices. That's one of the approaches mentioned in the SIR for developing an evaluation strategy. So Chris, in some ways is going to discuss some of the more practical aspects of doing an evaluation and developing an evaluation plan. Okay, let's turn to a discussion of the requirements from the SIR for evaluating promising approaches. And the material I'm going to talk about on the next few slides comes from Appendix C of the supplemental information request that was sent out in early February, as well as some information from the HomeVeed website. So the first thing to note is that HHS is interested in developing knowledge about the ability of the promising approaches to improve outcomes for families, and also in understanding the factors that are associated with the state's ability to support and monitor the quality of evidence-based programs. they're quite interested in gathering, a knowledge base about the effects of the promising approaches. One thing that should be said straight away is that states aren't required to conduct any particular type of evaluation, but whatever evaluation is conducted must be rigorous according to the SIR. And just to quote, of sufficient rigor to demonstrate potential linkages between project activities and improved outcomes. And the SIR describes 4 criteria for an evaluation to be rigorous. The first is credibility. By that it means that the results should be believable. They should be accurate. Things should be measured in a way that is credible. They should be accurately described. And whatever design is chosen should be the best one feasible for answering the question that is desired to be answered. The second criterion is applicability. And by that, they mean that the results should be generalizable beyond what the state is finding so that it's useful to others around the country who might be considering or implementing similar promising approaches. In addition, the population being studied in the evaluation should be a population that's actually being served by the home visiting programs. A third criterion is consistency, and that basically means that the results should be replicable by other researchers. The methods that are used should be described clearly enough that someone else could use the same approach and come up with the same answers. And the final criterion is neutrality, which really means that the results should be objective. Whoever's doing the research should be independent, and any potential biases should be acknowledged. Let's turn to a brief discussion of the criteria for evidence of effectiveness. So these are important because if a state wants to have a promising approach added to the list of evidence-based models so that 75% of MIE-CHP funding set aside for evidence-based models can be used, then it has to meet these criteria for evidence of effectiveness. And again, this comes from the SIR, so you can find this information. Actually, this comes from the SIR, so you can find that information there. So the first criterion is that the study has to have some sort of comparison condition. What's happening for families going through the promising home visiting approach have to be compared to something. And there are a number of different designs that we'll talk about in more detail later that could meet those criteria, including randomized control trials, or RCTs, and several types of quasi-experimental designs, or QEDs. These include matched comparison designs, where a group of families from some other part of the state or who aren't eligible for home visiting services of a promising approach are compared to families going through home visiting. Single case designs in which families are followed longitudinally over time to see what effect the promising approach has, and regression discontinuity designs. And I'll talk again about all of these in more detail later. Studies that use that comparison condition will then be assigned a rating based on the study's ability to provide credible estimates of the program model's impact. A highly rated study would be one that's a well-implemented RCT, or a single case design, or a regression discontinuity design. A moderate quality study would be one of those 3 types of designs, but with some problems, like a high attrition rate in an RCT, or a well-implemented matched comparison design. I should say matched comparison design, I think, instead of QED. And then a low quality study would be one that did not meet those standards for high or moderate quality. Continuing on, another criterion for being showing evidence of effectiveness is listed on this slide. So if the study is considered a high or moderate quality study, then there has to be at least one of those types of studies with favorable, statistically significant impact in 2 or more of the 8 outcome domains that are listed in SAR in the legislation. Or alternatively, there could be 2 high or moderate quality impact studies with non-overlapping analytical samples, meaning that there are different groups of families in the different studies, with 1 or more favorable, statistically significant impacts in the same domain. So, 2 alternatives for showing evidence of effectiveness. At the same time, here's another criterion. The impacts must either be found for the full sample, or if it's found for just a subgroup, then it has to be replicated in the same domain in 2 or more studies using non-overlapping samples, using different groups of families for those studies. So it can either be for whatever full sample of families you're studying, or if it's just a subgroup of families, those with particular characteristics, then it has to be replicated for that same subgroup in 2 or more studies. And there's one more criterion which only applies to RCTs, In the legislation, it's specified that if an RCT is used, then the effects have to be shown to be statistically significant, at least one of those, statistically significant and favorable for at least a year after program enrollment, and at least one statistically significant favorable effect has to be reported in a peer-reviewed journal. So again, this applies only to RCTs. Another slight twist. Final thing that's required in the SIR is that the updated state plans have to describe the evaluation. So there's a list of different pieces of information that the plan would have to include, and some of them are mentioned on this slide. At the same time, the state would have to identify the evaluator, which could be an in-house evaluator or it could be an outside evaluator. The key is that the evaluator has to be independent, has to be somebody who's not so directly connected to the program that they wouldn't be able to provide an objective analysis, an objective piece of evidence about whether the program is effective. The other piece of information that the updated state plan has to include is a logic model and conceptual framework that shows the links between services and outcomes, really kind of a theory of change of how the program is going to have its effects. I'm assuming that states interested in studying promising approaches would really find an evaluator first, either in-house or external, and have them provide the information that's required for the updated state plan. Okay, let's turn now to discuss briefly whether to actually conduct an effectiveness study. And in doing this, I think about two broad types of evaluations. One is an effectiveness study that is really trying to address the question of how much does the promising approach improve outcomes, or whether it improves outcomes for families compared to what would have happened without that approach. So that what would have happened is the reason that we need a comparison group to be in the study. The second broad type of evaluation is sometimes called a process study, and this is really more about whether the promising approach is being implemented as intended, and also if it's not, how could that implementation be improved? Are families receiving as much of the services as is desired? Are they do they seem to be reacting well to the services and that sort of thing? So a process study would be more about the process of providing services and whether that's going well. That can be really important because there has been research that indicated that well-implemented programs are much, much more effective than ones that are implemented with problems. Just to give you some examples of some questions that could be answered by the two types of evaluations, the left column here shows just a sampling of questions that could be answered through a process study, and the right column a few questions that could be answered through an effectiveness study. And again, these are just examples. Yeah, there are many, many more questions that could be answered. For a process study, that's interested in how the programs are implemented and what families are actually receiving could answer questions like how many families are served, how often were services provided, weekly, biweekly, monthly, how long did families participate, how many months did it go on, or years, or whatever the length of time might be. How closely did the services correspond to the model? So if families were supposed to be receiving services every week, did they get them every week, or was it less frequently? And then often process studies will include satisfaction surveys to find out what families thought of the program and whether there may be some indications of how to improve the implementation of the program. By contrast, an effectiveness study is really about whether the program has effects on child and parental outcomes and how much effect it has. So questions that might be answered through this kind of study are how much did child and maternal health improve because of the particular approach that's being studied? Was child abuse and neglect reduced? How much did child development and school readiness improve? So you can, write down questions like this for each of the domains or specific outcomes that might be of interest or that might be expected to be affected by the promising approach, and address similar questions. So gives you a quick sense of the differences. So which one should be conducted? What are the pros and cons of doing an effectiveness study really compared to doing a process study? The main reason to do an effectiveness study of these kinds of promising approaches is that an effectiveness study is needed to move the promising approach into the evidence-based category, and that can be important for the way that funds are used from the home visiting program. The second, sort of maybe more altruistic in some ways, reason is that an effectiveness study can really benefit the state and benefit the whole field in understanding which kinds of approaches work for improving outcomes for families and in what ways they work. So the world can learn a lot from those kinds of effectiveness studies. The cons are that the resources needed for an effectiveness study, because of the requirement that there be a comparison group, can be pretty high, so that might be something that rules it out for some states. As we'll talk about in a few minutes, for most of these studies, you need quite a few families to obtain precise estimates of the effects of the promising approach, and that might be beyond the scope of some of the promising approaches that are going to be used and the number of families that would be eligible for those approaches. And then the third reason is that often a process study is kind of important to do before the effectiveness study is done. The process study can provide information on whether the program is being well implemented and can be used to strengthen the program before measuring impact. Often it takes maybe a year or two, people have found in some circumstances, to get a new program up and running to the point where it's kind of stable and having its intended effect. And you may want to do a process study before doing an effectiveness study. And in most studies that MDRC does, for example, of new programs, there would be a pilot period in which the program is studied and attempts are made to strengthen the program if some issues are found in the way that it's being implemented. Okay, with that as kind of background, let's just briefly talk about several effectiveness designs, really the four designs that were introduced on the previous slides. The first design that I'll talk about is a random assignment or randomized control trials, as it was called on the previous slide, or RCTs. And in this design, families are assigned at random to home visiting or to a control group, or for a promising approach, they're assigned at random to the promising approach or another group. The group could be a control group, which could typically be able to use other services in the community. It could be another version of home visiting that doesn't include the promising approach. So it's possible the promising approach is sort of an enhanced version of a more standard home visiting model. One of the characteristics, of course, of using random assignment is that there have to be more families eligible for the services than are going to be provided services. So you have to have more families that are served in order to provide families for that control group. Sometimes, as I mentioned, it's used to compare two different approaches, for example, enhanced versus a standard home visiting approach. The main advantage of using random assignment is really evaluators think of it as the only method that's guaranteed to provide unbiased estimates of the program's effect if it's well implemented. The main disadvantage is that some eligible families won't be receiving the promising approach. So in a sense, you have to tell some families they can't get this promising approach, and a lot of times that can raise some ethical questions and so on that might make it hard to do. Just to give you a sense of how many families you would need to involve in a study, this table provides some information that shows potential sample sizes and something called a minimum detectable effect. The minimum detectable effect is the smallest true effect that would be likely to generate impact estimates that would be considered statistically significant, and that just means that they would be considered pretty good indications that the program was effective. So for and I should mention before I present the numbers, this slide is labeled random assignment. For a regression discontinuity study, which we'll talk about in a minute, you would need even more families. For a comparison group study or a matched comparison, you wouldn't need more families than this necessarily, but as we'll talk about, the matched comparison might just give you the wrong answer, so you just have some uncertainty in that regard. For single case designs, which we'll talk about in a while, these sample sizes are almost not really relevant. So this really applies to the other three designs more than anything else. So just taking the first row, if you did a study where you had 60 families and randomly assigned them so that 30 of them were in the promising approach, or what I labeled here the program group, and 30 were in the control group, the minimum detectable effect would be 17.5 percentage point reduction in depression. I use maternal depression as an outcome here because I know it's something that a lot of people in the home visiting world are kind of wrestling with. How do you work with moms who are depressed and make home visiting more effective for that group? I also included it because, as Nancy mentioned in the introduction, we're doing a study of Medicaid mothers with depression, and so I had some information handy to put the slide together. That's 17.5 percentage point reduction. In the study we're doing, which enrolled a group of mothers who were on Medicaid who were depressed when they entered the study, 88% remained depressed at follow-up. So this minimum detectable effect of 17.5 percentage points would be saying that the approach would reduce depression from 88% of the control group to 70.5% of the program group. So it's pretty substantial effect. You can see as the sample size increases, that minimum detectable effect goes down. One rule of thumb is that as the sample size quadruples, say goes from 30 per group to 120 per group, the minimum detectable effect will be cut in half, and you can see that the numbers go down as you go down the table. So it can be. I mean, I think these numbers are substantial, but not out of the range of what some prior studies have found in terms of reducing depression for very effective programs. Next, let's turn to a brief discussion of the use of comparison group methods, or what's called a matched comparison group on the previous slide. Here, the comparison group isn't randomly chosen, so families aren't randomly allocated to a promising approach or a control group, but they come from some other source. It could be a waiting list. It could be families who aren't eligible for home visiting for some reason. It could be families who are eligible but just aren't referred for home visiting. It could be those who don't decide not to receive home visiting. It could be families in other parts of the state who look similar to the families going through the promising approach. So just the idea that there's a comparison group that should look as similar as it can to the families who are receiving the promising approach, but it's not determined randomly. It's determined in some other method. And the main advantage, I think, of using this kind of approach is that you don't have to deny any family services the way you would with a random assignment study where the control group wouldn't be getting something. The main disadvantage of these comparison group methods is that they can be subject to what evaluators call selection bias, and the implication is that the results may not really indicate the effects of the promising approach. The idea that families who receive home visiting might be fundamentally different from the comparison group when that comparison group isn't randomly chosen. Maybe the families receiving home visit have more motivation to participate in home visiting and to benefit from the home visiting program than the comparison group. It could be all sorts of reasons. To the extent that the comparison group can be matched on demographics and other things that, other pieces of information that you collect, that's great. But there's always the possibility that there's some unobserved differences, like motivation, between the comparison group and the families going through the promising approach. And that means that the results would reflect those differences as well as the effects of home visiting. The third effectiveness design I want to talk about is called regression discontinuity. And here the idea is that often families are ranked along some, with some criteria, and you can, kind of put families on a scale from low to high. Families who come above a certain threshold would be eligible for the promising approach. In this case, families who fell below that threshold wouldn't be eligible for the promising approach. And the idea is that families near that cutoff are going to be similar to each other. Families on one side of the cutoff who are eligible are going to be pretty similar to families on the other side of the cutoff who aren't eligible. And so comparisons of outcomes for those two families are going to provide pretty good information on the effects of the home visiting program or the promising approach. The pros, again, in this case, you don't have to deny services to eligible families. You're using families who wouldn't be eligible because they don't hit the threshold as the comparison group. One other advantage is that evaluators think this usually provides pretty good estimates, pretty unbiased estimates for families near the threshold. A little bit, you have to meet some conditions that you wouldn't have to meet in random assignment, but it seems like in most circumstances it provides pretty good estimates. The main disadvantages are that it provides information really, strictly speaking, only for families near that threshold, and a lot of families are going to be, pretty far away from that threshold and really have some really high risks that would make them far from the threshold. The other is that it requires more families than the other designs to be eligible for the home visiting or for the promising approach. And the idea again is that a lot of families who are far from the threshold aren't going to provide a lot of information for understanding the effects using a regression discontinuity approach, and you need a lot of families near that threshold. If you think about the slide that we showed earlier, the number of families you'd have in a random assignment study, if you were thinking about a random assignment study with 30 families in the program group and 30 in the control group, here you might think of a regression discontinuity design with 30 families just above the threshold and 30 families just below the threshold, providing similar statistical power. And then finally, let me talk a little bit about single case designs as the last example of an effectiveness design. And truth in advertising, I'm not an expert of single case design, so I think everything I say here is accurate, but it's possible that someone who is an expert might disagree with something I say. The idea behind single case design is that you would get repeated observations of families both before and after the promising approach is used, and by observing the families multiple times before they receive the promising approach, you kind of allow them to form their own comparison group. So ideally, once the promising approach has been introduced, you see outcomes that are much different than after the promising after the promising approach is introduced. So the question is, does the trend in the family's outcome improve after they receive the promising approach, assuming that improvement is what we're trying to do. The main pros are that you can do this with pretty small sample sizes. If I'm reading the Home V standard correctly, you can actually do this with as few as 3 families in a single case design. And the Home V standards are based on some criteria put out by the Worth Clearinghouse. So 3 families is pretty good. You also don't have to deny family services, as you wouldn't also in for the previous 2 types of designs I talked about. The main con, I think, is that the intervention should really needs to have pretty large and pretty rapid effects for, I think, a single case design to be used. If you think about it, if you have 3 families, you really need to be able to show for all 3 of those families that the approach is having pretty substantial effects. And the examples I've seen in the literature really are looking at the direct targets of an intervention. So one example is a program that is trying to teach parents about how to keep their house clean. The idea being that dirty homes might have a lot of bacteria and children might get sick, and so the intervention is to teach parents about cleanliness, and what's observed over time, both before and after the intervention, is how clean the home is. And that's an example where you can see if the intervention is effective, the parents will change their behavior pretty quickly and clean up their home. So I think that's an example of that kind of direct target that you might expect to have pretty large effects for and pretty rapid effects. The other main con is that in order to meet the standards that have been set up, you really have to collect a lot of information on families, both before, during, and after the promising approaches put into place. I think the criteria say you need to observe families at least 5 times before the intervention goes into effect, and then there's supposed to be several phases, generally during the time of the intervention and then after the time of the intervention. And in each of those times, you're supposed to observe families 3 to 5 times. And each time, so which one would you choose? I think about this in terms of the following questions. Can you serve all families who are eligible for the promising approach? If you can, then random assignment is out, because it would be unethical to deny family services if they can all be served, and you're pretty sure there's good evidence that the promising approach should be effective. But if they can't, if there's a waiting list or if there are more families who are eligible, then there are funds available to serve them. Then randomization can be a fair way to determine who gets those services while providing the best evidence of effectiveness. So assuming that your randomization is out, for example, because you can serve all families who are eligible, the next question would be, are there quantifiable criteria that determine eligibility? So can families be ranked on some quantifiable dimension? If they can, then maybe and families above a threshold are eligible. If they can, then a regression discontinuity design might work, comparing families above and below that threshold. If the answer to that is no, next question would be, are the effects on the outcome that you're going to be studying pretty immediate and pretty large? In that case, a single case design with a small number of families might be the way to go. And then if the answer to all of those questions is no, then a non-random matched comparison group would be the way to go. But the main concern, as I mentioned earlier, is that the results might be subject to selection bias. So you never know what you're getting in that kind of study. So with that, I'm going to turn it over to Chris, who will talk a little bit more about some of the other, I think, more practical aspects of doing an evaluation and putting together an evaluation design.
Okay, well, thank you, Chuck. What I'd like to do is really kind of speak about this as design and implementation process from the view of being the state lead. And even if you're in the audience and that's not the role that you're in, part of what a participatory research method would really call for is that there be a shared group responsibility for really thinking about how does this go from conceptualization of the task through startup and then continuing overview of the successive implementation in the program. So in this first slide, I just want to hit a couple of general orienting points. If you're working with the issue of trying to evaluate a promising model, either this is a fairly new program that has not had the opportunity to move into a strong tradition of evaluation of its effectiveness, or it's a fairly mature program that also has developed kind of independent of that evaluation process. So one of the challenges presented at the state level in being able to respond well to this federal initiative is really managing this transition for communities and for practitioners into the business of being able to engage in some pretty high rigor evaluation. What we know now about the implementation of evidence-based practice is that successful effectiveness evaluation also then really requires staff who are ready to engage in this work, and the data collection and management practices embedded in the program delivery that really allows you to describe what you do and the outcomes that you're receiving. And it's around this evolution of staff, impacts on practice, changes in how it is that they collect information, that there's a fairly significant development task that would face states that are taking on this promising practice section of the Federal Home Visiting Initiative. What I think experience from the field keeps pointing us towards is that preparing providers and the communities that are receiving the services needs to be a pretty intentional developmental process, so that there's a stage of getting ready to implement the evaluation that needs to be very intentional. The next point is that we have a large body of information that says engaging in participatory research practices, really engaging the community, the agencies that are doing the services, the providers that are conducting the services, and the consumers leads to an increased quality of implementation and a greater buy-in in terms of the program. So I'll return on these participatory research methods again, but in responding to the federal request for proposals, coming through this participatory research lens is one of the explicit conditions for having a fully responsive application. So some of the things that we begin with whenever we start looking at this, and when you're looking at working with the providers and the model developers around your promising home visiting model, is that we really need to think in terms of how well have they been able to already position themselves to be able to answer some of the core research questions. And these come down to kind of three big organizing concepts that seem to consistently be the places where we have to return in our discussions over and over again. The first one is, do we really have clarity in defining and documenting the model's intervention? One aspect of that is really being able to identify, as you measure what you do, what you consider to be the active ingredients of the program. Why being able to really specify the active ingredients of the intervention becomes very important is that as you try to measure for the absolutely critical things that needed to happen in delivery of the intervention, these are where you have to keep returning to be able to know what it is that you've got to prioritize for measurement. It also creates the condition over the long term for really thinking about what does fidelity to this model genuinely mean. Second major area is, do you have the capacity to describe who you serve and what they need? What we end up seeing in all the home visiting literature is that variability in the people that enter care becomes one of the major explanations for ultimate outcomes. So we need to be able to understand who we're serving, how subgroups of participants are able to benefit effectively. Going back to Chuck's discussion, one of the things that we know is that maternal depression is seen as a major characteristic of participants in home visiting who have had pretty equivocal success in a number of studies that have been done. So as an example, really being able to understand the level of depression in a population coming into your home visiting promising program may be a very important thing that you need to really position to test. And then the third issue is capacity to measure outcomes that are aligned to the model's intention and to the capacity of your providers. So the first issue about aligned with model really pulls us back into thinking about how clear is the logic model that is driving the promising practice. And very often programs that have been in the field or are just starting up could benefit from really having the opportunity to go back and really look at the refinement and development of the logic model that will drive the work that you're all taking on collectively. The capacity for providers on measuring outcomes comes down to the level of skills necessary to collect the information. So there is kind of the abstract issue of what we intend to do, but there's also then the issue of, depending on how you try to collect the data, what level of skills are required to really be able to use the instruments that are being proposed. If we look at some of the kind of key steps to guide the evolution of effectiveness research and promising approach evaluation, some of the things that really are critical to the early development is, are the model's intervention activities clearly defined and defined in a way that they can be measured? And two major dimensions there about how you would think through answering those questions is, can you accurately describe the dose of service that's being delivered and have the means to collect that information? And then the second area that's a little more demanding but seen as being very important is that in the home visiting is the content session by session of what's intended actually being delivered. So this will give you some direction about how you really start to try to think about measuring what the promising practice actually looks like as families are participating in the service. Second is, can clients be clearly described within this model and described on dimensions that are logically related to the outcomes? Again, most of the programs that would be in the promising approach category for home visiting have not had to really address this very kind of tight, rigorous issue of measuring outcomes against the logic of the intervention. So this becomes a very important part of the early definitional discussions that will then drive the evaluation. Third issue is most of the folks that are going to be delivering these programs have not come from a tradition of being able to collect information and provide information into the data systems we usually would need to develop for evaluation purposes. So there often is a significant investment that needs to be made in many of the designs that we would use to measure the effectiveness of the promising model, to really look at staff development and staff skills to be able to collect and report information effectively. Fourth is that based on the very common needs that we see within families, we need to be able to look at measures that are culturally competent and appropriate to the populations that we're looking and again, this becomes a process of staff development to really be able to understand how to effectively use these kinds of instruments. The last point, in terms of really the steps to guide the evolution of a promising approach evaluation plan, is really setting up the conditions where providers, both at the agency level and at the line level, are committed to participating in high-quality evaluation and to CQI, continuous quality improvement. One of the mechanisms for doing this in any evaluation design is to build in feedback mechanisms back to the providers where information being produced by the evaluation actually helps to guide practice. This next slide is actually an example of a guide that we developed here in Washington, and this is associated with work that we've been doing under the Council for Children and Families, which is our Children's Trust program in Washington. So you'll see in the grayed top box, the State Coordinating Lead, CCF, is the Council for Children and Families. But I'm going to direct your attention into the blue circles and the boxes around it. One of the things that has evolved around evidence-based practice is a companion body of research and science about the implementation of how do we do evidence-based practice. So we can have very well-tested models, but as we move out into implementation, they become particularly difficult to be able to replicate the results. What implementation science has done is really told us to focus on the kinds of measurement and the use of information that can really help us guide this process of implementation to the best outcomes. So box 1 in the center is build and sustain the kind of relationship with organizations where they're fully committed to implementing the evidence-based practice, but also to collecting the information. Box 2 is really looking at the issue of match of the model to the agency that you're working with and the community that you're serving. 3 is really being able to assess the child and family characteristics of the participants coming into the program. 4 really looks at the issue of staff match and the need for staff development in implementation of the program. 5 looks at the issue of staff supervision as a critical aspect of implementation. 6 becomes information systems development, so that you actually have the ability to collect and use information effectively as it's being collected. 7 is really creating these feedback loops so that you have information-driven clinical decision-making. And 8 is the issue of beyond the clinical implication of the information, that you're actually creating a culture inside the delivery agency to use information to drive continuous quality improvement. Up above that blue cycle of development are the other kind of stakeholders and major communication vehicles that need to be addressed in any system. And we wanted to provide this as one example of how you actually start to think about translating from a logic model into an action and development model for moving into implementation-based research. Wanted to hit a few high points about the issue of building an evaluation and implementation team. Choice of language there is very intentional. From a state lead perspective, you have a critical role to play in really making sure that the implementation and evaluation sides of your work are fully integrated in a common implementation plan. One of the challenges here chronically as we work out into these kinds of community-based research activities is really making the adequate investment in evaluation and then building the support for the level of investment. As a general rule, it would be wise for you to be thinking in terms of 15 to 20% of the overall budget would really need to be dedicated to being able to deliver the caliber of evaluation plan that federal guidance is calling for. There are many ways that you can think about hiring a specific evaluator. I think my experience working in this field for a number of years is that the closer your evaluator is physically to the program delivery site, the easier it is to build team and create the very effective communication mechanisms that you need. But I do want to acknowledge that what you want is the strongest evaluator, but would keep returning to this issue about one of the distinctive roles of state leads can be to really set the conditions and expectations for very high level communication and coordination between those who are implementing the programs and people responsible for the evaluation. Participatory and empowerment evaluation really is a set of values about how you conduct work, and a way to really think about this is that this is very much about governance of the process and opening the table of governance to include people who may not often actually get involved in oversight and design decisions. And the kind of classic people who we usually leave out of the table are the consumers of the services that we're providing, key community representatives, and the providers who are delivering the service. But these representatives bring a very, very distinct practical voice to being able to build the effective plan and create the benchmarks for how it is that you need to look at the quality implementation of the work that you're doing. When you're working into more culturally diverse communities, which is often the case with many of the promising home visiting models, this becomes absolutely critical, because you can have a perfectly effective model that is not seen by the community as convergent and supportive of the values in the community. So the only way you can open those conversations is to invite leadership and voice from participants and community representatives to be part of this as a review process. So when we look in terms of the steps in this evaluation process, really thinking through who are the key participants, the roles that they have, decision-making and communication efforts, that I would suggest is a really distinctive place for the state leads to not have just a design role, but a continuous role to make sure that this high-quality decision-making is continuously being done. You need to work towards establishing a formal research agreement. So this is a process of engagement into the community and securing their consent. It's addressing question intents and roles around the home visiting process and making sure that they're participating in this decision-making process. It's really, again, back to a critical role for the state lead is to be involved in maintenance and development of this collaborative, and assuring that learning is not something that is delayed until the end of the project, but is embedded in a continuous conversation about what it is that you're learning as you're moving forward with the evaluation of the promising practice. Again, some of the kind of core dimensions to really focus on in the design plan is really being sure that you've got the clarity of the theory and the problem statement, the focus of what the promising home visiting model is, that you're able to really document the evidence base that supports the logic of what it is that the program is providing, that from those first 2 points you can define the very explicit research questions and methods that you're going to employ, and that then through consent process with providers and with the community, you're looking at including them in selection of the rigorous research implementation methods, whether it's a randomized controlled trial or any of the other designs that Chuck had laid out. And finally, it's a matter of looking to use process evaluation to really address the quality and fidelity of implementation of the service, as well as success in implementing your research design that you want. It's really continuously staying attentive to changes in the external environment, or changes in within the population of people being served that could really challenge your ability to draw conclusions at the end of the day for the evaluation. And again, returning to introducing this idea of all will benefit if you can open the table and allow people from the community and the services and the population being served to actually be part of the design process. So I think I'm going to turn this over to you now, Jill.
Thank you, Chuck and Chris. This information will be very helpful to the states, tribes, and territories who are planning their evaluations of promising approaches. As Nancy mentioned in the beginning of the webinar, this webinar is just one source of support we are providing to the MIECHB grantees. So please stay tuned for additional webinars in the future, individualized TA, and other information from the Dev Evaluation team. We plan to provide TA on topics such as developing evaluation plans, helping develop logic models, identify data collection methods and sources, develop IRB protocols, and analysis strategies. We also have 2 calls planned right now. One is scheduled for April 20th, and that is a part 2 to the first continuous quality improvement webinar that we did. Again, that's the afternoon of April 20th. And then the following week, we have another call where we're talking about a measurement tool that was developed to help states track screening and referral, the referral and coordination of services for their families. We are also working on finishing up a brief or a memo on selecting evaluation or measurement tools and setting benchmarks. And in addition, if you are interested in receiving individualized TA, please contact your regional project officer or your federal project officer to submit a TA request. This is a list of the webinars that we've conducted. And at the bottom of the screen, you can see the website. This has links to all of the archived webinars as well as slides for today's webinar. There's also another website, the ECCS home visiting website, that contains links to all of the webinars that have been conducted across all the different projects for the MIECHB grantees. Okay, so now we're going to turn to the questions that we have received through the Q&A panel. As a reminder, if you would like to submit a question, you can do so at the bottom right-hand corner of your screen. We have received a lot of questions today, so if we don't get to your question, we will post responses through an FAQ that we'll post on the DOVE website. So the first question we have is for Chris, and the question is, how does cost factor into choosing a design?
That's a great question. I think that one of the real challenges here is that you are dealing with design at the state level on the promising practices with a capped amount of money. And one of the implications of that is really thinking about how much can you either embed some of your evaluation activities directly into the service delivery process, and how much do you have to set aside to really deal with the issue of potentially collecting information from a comparison group. Mostly as we've been doing this work in pretty modestly funded state evaluation works, we've kept opting for really looking at embedding the collection of information into the routine practice of the home visiting model. One of the challenges of that is that as you ask the home visitors to collect information, to some degree you're actually potentially changing the practice, so it's got to be done very intentionally. But we found that the economies that come from being able to really see evaluation as an integrated part of the clinical service delivery has paid off pretty effectively.
Okay, great, thank you. And a follow-up question to that is, how do you usually estimate how much each piece of the evaluation should cost?
Chuck, would you like to comment?
Can you repeat the question? I thought it was going to Chris, though.
Yes, the question is, how are grantees supposed to estimate how much each piece of the evaluation should cost?
Well, that's a tough question as well. I mean, I think I would say the main approach probably is to really find someone who can do the evaluation and start talking about what the requirements would be for that evaluation. There are going to be different components, data collection, the analysis, and so on. And really, it requires, I think, somebody who kind of understands those details to really think about what the level of effort would be to do different types of evaluations. It's not a question that I think there's a definite answer to. I know, Chris, you may have more to add to that.
Yeah, I think just a couple of things to keep in mind. I would absolutely agree that you've got to get to bring the technical expertise of the evaluator to the table with you in that kind of a design question. And then a lot of this gets driven by determining what the particular design is that you're going to use, whether it's a randomized control comparison group study or a quasi-experimental study. The emphasis, I think, that often gets missed, so this is try to give something a little more substantial in response to the question, is that we tend to bypass kind of the costs that are involved for the people who are actually either the delivery agency or the providers. So one of the things I think that I would offer in response to the question is really including an analysis of what the cost is going to be to really get your providers skilled in being able to deliver the program. Another point in terms of areas where people may not think about this is we've had a great deal of success in being able to present honoraria to families that are participating in research. And it doesn't have to be very much. A $5 or $10 gift certificate can be a huge incentive and a statement of respect to the people participating in sharing their stories as part of the evaluation. So short take is you need to really look at the design, talk to your evaluator about implementation, but I did want to highlight a couple of places where costs often get left off the table until the very end.
Great, thank you. We'll stick with the budget questions, and here's another one for you, Chris. How do you envision the certification processes and TA of model developers fitting with the evaluation processes?
Yeah, I think, again, it becomes an issue of some of the preliminary conditions that you need to make to be able to launch the successful evaluation. So to the degree that the model developer has really set up training and development, staff development standards that have to be met before you can implement, that becomes part of the preparatory work before you can really move into fully testing the evaluation. Do really want to advise, and the kind of experience that we've had is that the temptation is to sort of jump into data collection immediately, but a very time-limited, well-designed startup phase, including things like meeting certification standards for all staff before you launch data, is going to make sure that you get the greatest efficiency from the investment you make in the formal evaluation plan. I I think at that point, that's a great example of where you're really having to look at an integrated design plan between implementation of the intervention and the implementation of the evaluation step. Our experience working with several model developers from our base here in Washington is that model developers tend to be very open to this, because if they're in the promising practice approach area in this federal build out, they know they need partners at the local level, and you may be able to actually get some value added and some in-kind supports from talking to the national model developers about how they can help leverage some resources into this discussion. And we found in the main that national program developers have been very receptive on these conversations. They know that they need this data as well.
Great, thank you. Well, Chris, we'll give you a breather. This question is for either Lauren or Nancy, and the question is funding set aside in state grants to conduct either type of study, so the process or the outcome evaluation, or does this need to be raised from private sources? If it's part of the federal grant, how much is allocated to evaluation?
Hi, I think this is Nancy. I think Lauren was possibly going to cover that. So I apologize.
Oh, hi. I'm sorry. I was muted. So, Jill, that was a lot of questions in one question. Can we start with each question at a time? Can you just repeat the first question first?
Absolutely.
Thanks.
The first question is funding set aside in state grants to conduct either type of study, or does this need to be raised from private sources? Okay, so there's a lot of elements in that question, and hopefully I'll remember to address all of them. The first element is that so the evaluation funds for the promising approaches must come out of the 25% that's allowable for promising approaches. If a state is interested in doing evaluation on an evidence-based approach outside of the promising approaches, that those funds would fall under the general funds. And you can, there's a brief discussion about that on page 16 of the SIR. So you can use grant funds to fund the evaluation. However, I would say that, as I think Chris has already alluded to, that there may be private entities that can provide some either fiscal leveraging or other kind of support that I would encourage people to look into. There are a number of foundations that are quite interested in home visiting and in evidence-based practice, and I wouldn't rule out exploring some partnerships, especially given that evaluation can be expensive. I think I hit all the points in that first question.
Okay, so the second part is if it's part of the federal grant, which you said it can be, how much is allocated to evaluation?
So we're not giving a specific amount on how much is, there's no requirement around what percentage must be allocated to evaluation. We will be looking in our review of the state plans, though, for an appropriate budget. So it'll depend on a lot of the variables that Chris was just discussing about the design chosen and whether that design is, and how much that particular design might cost, and ensuring that the budget is sufficient to do a well-run, well-designed evaluation as planned.
Okay, thank you. And a follow-up question around the evaluation is, does the evaluator have to be university affiliated?
No.
Okay, that's a great answer. Okay. All right, we'll move to the next question then, unless you have something more to say.
I mean, I would just repeat again what I said in the earlier slide, that as I understand it, the evaluator has to be independent, but it could be an in-house person who's not, affiliated with the program, who could be thought of as providing independent evaluation. It could be someone, an evaluator at a place like MDRC, and not, non-university researcher. So anybody who's independent and can do evaluations, I think, qualifies.
Thanks, Chuck.
Okay, the next question. If the home visiting program being implemented is actually an established evidence-based program, can studies conduct a process evaluation focusing on the assessment of fidelity only, or do they need to have an effectiveness study as well?
So if it's an evaluation that a state or other grantee wants to conduct on one of the 7 evidence-based models, and then there is it's pretty open about the kind of evaluation you would want to conduct. Now, I will also say that I know that I've heard there are a few states that have some acceptable enhancements, adaptations on evidence-based programs that the model developers are saying are fine, and they'd like to test those further. And in that case, in order to move one of those enhancements onto the evidence-based website, the design would have to be an impact evaluation and meet those standards, but there's no specific requirements around that.
Okay, and then similarly, if a promising practice has been peer-reviewed and published as a randomized controlled trial, do they still need to do an effectiveness study?
So, in order to qualify to be on the list of evidence-based models for the Home V review, the program must have either the impacts in 2 different domains, a higher moderate quality study in 2 different domains, or in 2 different higher moderate quality studies having impacts in the same domain, so essentially replicating the results. The requirement around the peer review requirement is this sort of quirk in the legislation that refers only to the randomized control trials. And so if the promising approach is being tested with a randomized control trial and they want to move on to the Home V list, then that peer-reviewed requirement would kick into place. But I'll remember that only one of those studies of the higher moderate quality studies needs to be in a peer-reviewed journal. I know it's very complicated and challenging, and it is explained also on the Home V website.
Okay, thank you. The next question is, if a grantee is interested in a public health approach to evaluation, can any of the speakers talk about analyses with small n's, especially regression point displacement design, basically examining aggregate level impact of evidence-based programs in communities compared with others?
I'll jump in. Chris, sorry, you want to?
Yeah, actually, that's not an area of design work that I'm familiar with.
I'm not that familiar with it either. I just wanted to, say the requirements for the evaluation are kind of, what we described and are listed in the various sources. So, having a comparison group and that sort of thing. So if it meets those criteria, I think it would work. Lauren, is there a process for, it seems like the criteria for things like RCTs and single case designs are pretty clearly spelled out. Is there kind of a process for figuring out whether other kinds of designs meet the criteria?
It's our hope over time that we'll be able to do some of that work. As you might imagine, it's actually very intensive and very time-consuming work to develop those standards, and the standards are based on a lot of empirical work that's looked at the bias introduced in impact estimates in various designs. And so we intend to start, we hope to start taking a bite out of that, but there's a large field out there, and I'm not sure exactly what design we'll start on and when we'll be able to start that work.
Okay, here's another question as a follow-up to this previous question. Can any of the speakers talk about non-random comparison groups with propensity score analyses, especially nearest neighborhood matching and or propensity weight analyses? The participant understands that these are some ways to minimize selection bias.
Yeah, those are great examples of matched ways of finding a matched comparison group. So it would fit under that that design. The potentially score matching or other methods would be ways of coming up with a comparison group that has similar observed characteristics to the families that are going through the promising approach. So it fits squarely in that category of design.
Okay, thank you. The next question is for Chris. Chris, can you speak to the ways that you worked with different programs as an external evaluator in order to facilitate the ongoing communication and dialogue?
Sure. One of the first steps in working into either a system or a single agency about doing this work as an external evaluator is to really address the issue of a evaluation design review team. And this becomes really the vehicle for returning to this issue of how do you open both communication and the design discussion to include a variety of participants. And in a participatory research effort, this becomes really one of the very first tangible places where you're able to really implement a different way of engaging community and consumers about participating in the work. The whole core of the participatory research idea is that all parties associated with the program are experts in aspect of what's going on. So one of the ways that I've viewed my role as an evaluator working into these kinds of systems is to really be there to help create framework, create and explain decision points, be able to make technical recommendations about the options that are facing the group who's responsible for making these decisions, but to really push towards, wherever possible, a consensus-oriented approach to decision-making. I want to come back to a point that I'd made during the presentation, and it's kind of the distinctive role of the state lead, or if it's not the state lead, the whoever has got responsibility for oversight and contractual obligations associated with the implementation of the promising practices home visiting model and the associated evaluation. As an evaluator, I'm at my strongest if I'm acting first as an advisor to the overall process, and then secondly as a person who's got specific bounded responsibilities for implementation. The role of the state lead or designee is to hold the whole planning process together so that the issue of shared values, how we reach consensus, when consensus cannot be reached, who ultimately has the responsibility to break in and pass and make a decision, is an absolutely critical role, and one in these kinds of complex distributed systems often gets pretty fuzzy about who to deal with that. And I think that one of the early design steps and benefits that will pay back over time is being very clear about how do you create that group where the evaluator can come in and constructively contribute, but who actually is convening the group and ultimately has responsibility to make decisions if consensus cannot be reached.
Thank you. Do any of the other speakers have anything to add? Okay. Well, we've gone through the questions that we received, so I want to give everybody another few seconds to submit a question in the bottom right-hand corner of your screen if you have any. Okay, well then this concludes today's webinar. We hope to continue this conversation through future peer learning opportunities and individualized TA. Again, check back to the website for the archive of this webinar. Thank you very much for your time.
Ladies and gentlemen, that does conclude the conference call for today. We thank you for your participation. You may now disconnect. Have a good day.